Hi, my name is Thomas Pittenger, and I'm going to be going over psychopharmacology and alternative intervention strategies. All right, first off, we have anxiety disorders. So we have primary medications, which are going to be SSRIs, selective serotonin reuptake inhibitors. Secondary medications are going to be SNRIs. These are serotonin norepinephrine reuptake inhibitors. We have tertiary medications, which are like benzodiazepine. And these are supposed to be used more short term because these are kind of dependency type risks. So make sure that we exhaust other options. Alternative intervention is going to be like CBT, then mindfulness type training. All right. Now we have bipolar and mood disorders. So we have primary medication, mood stabilizers, and then second generation antipsychotics, particularly for mania. We have secondary medication, antidepressants in combination with mood stabilizers or alternative antipsychotics. Tertiary medications, so adjunct therapy. So this is just a combination of antipsychotic and mood stabilizers. So alternative interventions can be psychoeducation, interpersonal, social, rhythm therapy to help regulate mood cycles. Right now, personality disorders. Primary medication is going to be SSRIs for affect dysregulation or mood stabilizers for any sort of impulsive control issues. So we have secondary medications. There's going to be second generation antipsychotics for short-term management or transient psychotic or dissociative type symptoms. And we have tertiary medications, which is again adjunct therapy, so combination, low dose antipsychotics, mood stabilizers, antidepressants, depending upon comorbidities. Then we have alternative interventions, so this is going to be like DBT for BPT or BPD, and then there can also use a schema-focused therapy. So we want to make sure that these medications are known to just address the symptoms rather than underlying personality type structure. So psychosocial intervention is going to be critical. All right, next we have schizophrenia spectrum disorders. Primary medication is going to be typical or even second generation antipsychotics, so like risperidone. These are used to help treat positive symptoms like hallucinations, auditory, visual hallucinations. Secondary medication is going to be clozapine. This is used for people who are treatment resistant, primarily to like primary medications, um, or more or less having a combination of two different antipsychotic medications. Tertiary medications, very similar to the adjunct mood stabilizers, and antidepressants for any other symptoms that are still affecting the individual despite antipsychotic use. Alternative interventions are going to have CBT, so this enhances cognitive functioning. So this is going to be important for social skills, work performance, and just overall daily functioning. So we want to make sure that there's some sort of long-term adherence um, to treatment because there can be issues, and we want to monitor side effects, specifically medical side effects, like changes in metabolic levels. Yeah, we have trauma adjustment disorders. Primary medication is going to be SSRIs or SNRIs. This is for depressive anxiety symptoms linked to the disorder, so PTSD, particularly SSRIs. Secondary medication is going to be prazosin. This is primarily used to help like with the nightmares in relation to PTSD. Then we have tertiary medications with second generation antipsychotics or mood stabilizers for more complex trauma issues or those who have multiple conditions. Then we have alternative interventions. This is going to be like EMDR or MBSR, so in order to help manage any sort of stress, anxiety, depression, pain, other trauma-related symptoms. Want to make or be noting that adjustment disorders can have like shorter duration, require more immediate intervention. Right. So social workers ethical responsibilities. So these are from the NASW. You have social welfare. This is promoting general welfare in society, communities, environment. And you have public participation. So make sure we've inform the public in order to shape certain policies. Then we have public emergencies, provide professional services in dire needs. And then there's social and political actions, so just ensuring that there's equal access to resources, services, and opportunities for all individuals. So we have to make sure that social workers are able to challenge the systems that basically just promote a lot of overprescriptions. So we have like these pill mills that need to be addressed. Want to promote equitable access to evidence-based, non-pharmacological interventions, and we also want to participate in policy making, particularly around like marketing and regulation and just overall mental health care type resource funding. Right. So the example I have here is going to be PTSD. So for the medication limitations, so there are a few medications that are really approved for PTSD by the FDA. So SSRIs are one. So we have SSRIs, SNRIs, second generation antipsychotics, which can help reduce PTSD symptoms, but the benefits can be moderate and vary between clients. So there's some limitations and high rates of non-response or partial response, although many people can remain symptomatic. We have medications that often address symptoms, such as like PTSD re-experiencing, avoidance, hyperarousal, but not target underlying trauma type things that need to be processed through therapy. There are adverse effects, and there can be some tolerance issues to the side effects, so people are not able to tolerate the side effects. So they end up not wanting to use it. Medications alone can essentially interfere with their engagement in therapy because they can feel sluggish or just not themselves. And they can also be misused. So there is uh, basically lacking any sort of like long-term data with in regards to like maintaining remission for just like daily functioning of these individuals. Yeah. And then alternative interventions for PTSD. So trauma-focused therapy, EMDR, prolonged exposure, trauma-focused CBT, or even MBSR are going to be the ones that are primarily used. So there is a comprehensive review of clinical trials found that psychotherapy is better and longer lasting in reduction of PTSD symptoms. We have different types of therapy, including written exposure therapy, uh, which, when used compared to just using SSRIs, has about an equal uh, advantage to SSRIs. Um, but again, it requires people to just be more involved and engaged. And then MBSR has more or less been shown in clinical trials to reduce PTSD symptoms to improve emotional regulation. Psychotherapy, it directly addresses trauma, memory of avoidance behaviors, and integrates traumatic experiences rather than modulating any sort of neurological issues. Non-pharmacological treatments are used to empower patients and help them develop more skills with coping and emotional regulation. And of course, have or do not have the side effects like medication use comes with. So combining psychosocial intervention with medication yields typically higher outcomes and long-term stability than just medication alone. So social workers really need to prioritize trauma-focused psychosocial interventions and use medications in combination as adjuncts rather than just sole treatment and getting clients to get medications. And we should also be monitoring the clients and their symptoms. All right, that is all. Thank you very much for listening to the presentation.